Assalamu alaikum. So today we will discuss this pregnancy-induced hypertension. So my first question, if anyone please answer, what is difference between PIH and preeclampsia?
Proteinuria.
Okay, and what else? Yes, please. Actually, you have jumped to the answer. If you just elaborate your answer in a better way, it will be better. It will be good. Like pregnancy-induced hypertension. Yes.
Sir, like in PIH is pregnancy-induced hypertension, like hypertension which occurs like high blood pressure, systolic blood pressure more than 140 and diastolic blood pressure more than 90 millimeter of mercury, which occurs after 20 weeks of gestation in a previously normotensive patient, and without which is recorded at two different occasions at least at 4 hours apart.
Yes.
And there is no proteinuria in PIH.
Actually, there are some other definitions which are actually practically not important, but sometimes they ask in the exam. What is pregnancy-associated hypertension? There is another terminology like that. Pregnancy-associated hypertension, even I don't know, because but I have heard that there is one terminology, pregnancy-associated hypertension. And another thing is that if you have a pregnancy, if you have a patient, hypertensive patient, and now that patient get pregnant, so what will you name it? Name that person? Yes, Sumaira.
So there is chronic hypertension superimposed with PIH.
Yeah, actually these are terminologies which, if you ask me, these are not important, but unfortunately and please remember one thing, especially for you, because you are going for Viva. So I will say that don't be afraid, even if they ask you and you are not able to answer such questions. These are not failure questions. Okay, if you are not able to answer this question, it will not make any difference, but you should be just knowing the difference, that it is pregnancy, like preeclampsia is hypertension after 20 weeks of gestational with edema and proteinuria. Okay, if you can reduce the background noise, it will be very good. Is it possible? Because there is so much background noise from you. Okay, so when you have now patient with preeclampsia, okay, so what is the basic pathology of PIH? What happens actually?
Sir, in PIH, in pathophysiology, there are different factors like immunological factors, genetic factors, endothelial factors, and other like platelet factors, and mainly one factor that is immunological factor. What happens in normal pregnancy? What happens like there are trophoblast cells which causes the denervation, adrenergic denervation of the spiral artery, maternal spiral artery, and it leads to the dilatation of the arteries and decreases the resistance. But in PIH, this process fails.
So what happened?
So there will be contraction of the spiral arteries, and there will be high resistance, and there will be a decreased blood flow to the placenta. There will be placenta insufficiency.
Very good. If you just make it a summary, if someone asks you in detail, you can answer in this way. But if you make it a simple answer, that it is an abnormal placental implantation, okay, resulting in disorganized blood flow, and there is imbalance between vasoconstrictors and vasodilators. Okay, what is the main vasoconstrictor?
Sir, prostaglandin, PCI.
No, that is dilator. Prostacyclin is the dilator, and thromboxane A2 is the constrictor.
Right.
Okay. So there is vasospasm. Okay, the resulting will be that there is like abnormal placental implantation. There is resulting in this all those factors. So in the body, there is generalized vasoconstriction. So whatever problems will be, these are the details you can see: pro-angiogenic factors and anti-angiogenic factors. I will suggest you not to peep into it unless they ask you. If they ask you, then you should know about but if they ask you what is the pathophysiology of this preeclampsia, what happens in preeclampsia, that there is abnormal placental implantation, and there is resulting in this decreased perfusion and all the cascade which is occurring after that. Okay, this will make your life easy. Okay, so what other presentations, like what other sign and symptoms can occur in this preeclampsia?
Sir, in preeclampsia, there will be proteinuria like 300 milligram in 24 hours urine specimen, and there may be a renal in dysfunction, thrombocytopenia, pulmonary edema, cerebral or visual symptoms.
Okay, what else?
And there is also a doubling of the creatinine, a normal creatinine level. If it's 1.0, then it will go to 2.0 in some cases.
Yes, there is renal insufficiency. Okay, there is renal insufficiency. So actually, there are generalized body symptoms in whole of the body. Like if you name them, there may be, is it possible to decrease the sound? There is too much sound. Yes. So there is what will be the problems in the central nervous system? Yes, Sumaira or Yasin, whosoever wants to speak out. iPhone. Yes, please.
Sir, in central nervous system, there may be intracerebral hemorrhage, cerebral edema, visual disturbance.
Now you see, you have told so many fancy words which are not wrong, but you are not telling the first thing, which is usually the presentation. It is part of
Sir, headache and visual disturbance.
Okay, so try to be simple, Sumaira.
Seizures.
Okay? Seizure can, of course, that if it is, yes, this is the difference, that if seizures occur, this will not be labeled as preeclampsia. It will be labeled as eclampsia. Okay, understand that this one, the difference between preeclampsia and eclampsia is preeclampsia with seizures is eclampsia. Okay, so that's the triad which I was telling you, that there is hypertension, proteinuria, and edema. Okay, this is the triad of preeclampsia. And yes, you see the symptoms, relevant symptoms which can occur, like headache, visual disturbances, there is blurring, flushing, upper abdominal pain, nausea, vomiting, swelling of face, feet, and hands. Okay, brisk tendon reflexes. This is showing the central nervous system irritability. Upper abdominal pain is because of involvement of which organ? Usually
Liver.
liver. Okay. So visual disturbance is because of the thing which you were telling. Because if they are asking you symptom, even if they are not asking you what is the clinical presentation, try to start with symptoms. Okay. So in that way you will not forget. So visual disturbance is because of usually because of cerebral edema. Okay. So like the and even this condition, when we quantify it and we say that it is severe preeclampsia, and that can lead to eclampsia. Okay, so this is how you should be memorizing it. And then other all symptoms like coagulation factors can be affected. There may be generation of this HELP syndrome, in which there is hemolysis, low platelets, and elevated liver enzymes. This is all according to the severity. Okay, so there will be clinical. Now you just think, what are clinical symptoms, what are signs, and now what third thing will be, what are the investigation which can be there. So patient may have platelet count may be low. Okay, coagulation may be disturbed, liver enzymes may be raised, and as Yasin told, that there may be involvement of kidneys. So if there is involvement of kidneys, so creatinine will start going high. Okay, so that is one thing. And then there will be proteinuria, as I told you. Okay, so when there is significant proteinuria, when there will be low albumin, this is one of the factor for edema. Okay, so it is core in interlinked. There are some, actually I wanted to check it out, I forgot to. If anyone knows why this serum uric acid is raised in preeclampsia.
Sir, usually that uric acid is excreted through the kidney.
Mhm. Is it only because of renal dysfunction,
So
or
when
there
there
is
is
some other
renal
reason?
changes,
I just wanted to clarify that, is it only reason of increased serum uric acid is only because of renal dysfunction, or there is some other reason as well? That's the only thing which I wanted to know. If anyone knows, you can share. Okay, but I think your explanation is,
Increased protein catabolism, I think.
yes, this is also maybe a reason. You are absolutely right. This may also be a reason. Okay, so you just check it out. Actually, remember, again I repeat that sometimes when you are reading so many things, even the people, the juniors who are listening to the discussion, remember one thing: try to have the chunk first. Don't go in tiny minute details. If you know the big points, the questions usually will be from big points. Yes, they can make a very small point, but if you have the basic concept, then it is possible that you will be able to understand the minor details as well. If you only know the minor details and you don't have the grip on the chunk of the subject, the base of the subject, then you will be in trouble. So up till now, if you can just recall what I have told you, that it is a condition in which in the later half of the pregnancy, there is hypertension, there is this one, edema, proteinuria, and then multiple systems may be involved, and severity may be increasing. If you are not able to control the blood pressure, then all the serious complications sequelae can occur. So it is one of the cause for mortality or morbidity in the pregnancy. So that's how you should be just a step up. Even if you have severe preeclampsia, there may be involvement of cardiac system, because the cardiac system is already under load. So there may be, like, patient have physiological anemia as well. So maybe this may lead to like ischemic symptoms. So this will all be maybe interlinked. If you have a patient where there is like a heart failure occurs, then pulmonary edema can also occur. if there is hypoalbuminemia, this itself is a risk factor for pulmonary edema. Okay, so you can just correlate one thing with other. Okay, so the just these that per the terminologies which I was telling you. Pregnancy induced hypertension, new hypertension presenting after 20 weeks gestation without significant proteinuria, or you will say it pregnancy induced hypertension, okay, or gestational hypertension. There may be chronic hypertension which can occur before it. Okay, so that's how. And even after pregnancy finish, okay, even then it will the patient might develop chronic hypertension after it. So that's why it's always advisable to follow up these patients, because the patients who are taking treatment for hypertension during pregnancy, there is always a chance that they may develop chronic hypertension. Okay, usually it will be reversed, but you have to follow with it. Okay, in if you are appearing in the exams in international like British exam or European exam or Irish exam, they ask again. I told you that you should be following the latest CMAC, confidential inquiry into maternal and child health. So the percentages are changed in every report usually. Okay, I had put the last report when I was studying, and I think after that there is one more report which I don't have the access. I think I couldn't find the report. So if you any one of you have, just please do share it with me, because this is the important thing about it. Okay. So now comes like they can ask you how to classify it like any other hypertension. There is no science, almost the same thing you can tell, like just like class 1, class 2, class 3. They have, I think here they have just labeled a little, because in class 3 usually it is 180. In this text they have written 160. So you can reconfirm about it. Okay. And this question should not be asked to you, but of course this is actually like a concern related of gynae ops, but anesthetist is everywhere and he should be knowing everything. Okay, so you should be knowing that what are the risk factors for it. It can occur, first pregnancy and multiple pregnancies, so this makes funny. So it can occur in any patient, but if there is a history, previous history, there are always a chance that this patient might have another incidents. Okay, so you see, first time father, I don't know. So yes, so these are some of the complications, because whenever fetal circulation will be compromised, there will be effects on fetus. So it is one of the factors for IUGR. It is one of the factors for low birth weight, factors for there are so many things which can occur in the fetus. Okay. So as I explained to you, generalized vasoconstriction and decreased circulatory volume. So remember one thing, that whenever you are giving spinal to a patient with PIH, this preeclampsia, please remember this thing, that because you are worried about giving too much fluid, but still in this patient, if you don't do the preloading, you will have exaggerated hypotension as compared to a normal patient. So this is a practical message to all the juniors. Please, if you are dealing a patient, such patient, if you are worried about giving too much crystallite, you can give at that time. Before that, you can co-load or preload with colite if you are worried about it. Otherwise, this patient, you should be expecting that the patient will have hyper response as compared to a normal patient. Okay. And because there is increased vascular permeability, this is in addition to that hypoalbuminemia, this is a factor for edema. Okay, left ventricle failure can occur. Central nervous system, as I told you, headache, a visual abnormality, vomiting. This is all signs of raised ICP or like cerebral edema. Okay, altered mental status, and then there may be cerebral hemorrhage, as you told to start with. And then if it does occur, there may be convulsions. Okay, Generalized edema with enhanced upper airway edema. This is actually because of prostaglandin. Even in pregnant patient without any complication, there is airway edema. Okay, so this may be exaggerated. Okay, and they again the same thing: non-cardiac pulmonary edema due to capillary leak, GFR, endotheliosis, and microthrombi. The GFR is reduced, creatinine clearance will be reduced. Okay, so uric acid, as we discussed, that it is because of renal failure, and maybe there is also hyperprotein catabolism, as one of our colleague said. So, but don't go into the details if they are not asking you. No need, no need to peep in, especially for oral exam. Only answer the things or only utter the word which you can explain. If you dare not explain, try to avoid it as much as possible. Okay. So abnormal liver function, as I told you, this subcapsular hemorrhage and rupture, this is maybe a reason of abdominal pain. Okay. So altered coagulation, increased turnover of fibrinogen, fibrin platelets, and thrombocytopenia, DIC, patient can go in DIC. HELP syndrome. Okay, as I told you, this one, a decreased placental perfusion, placental ischemia and infarction, small for dates, IUGR. Okay, and it is also a risk factor for preterm labor or abruption, or even IUDs. Okay, this is okay. So now if I ask you that what are the challenges, if Sumera, please, you have to answer this question, that what will be as an anesthetist, because usually this will not be a long case, it will be a table viva usually. Okay, so what if they ask you, even this question is also for the juniors, that if you are having a patient with the PIH or preeclampsia, what are the challenges, what are the main concerns you should be looking at? Yes, please.
Sir, main concerns will be related to patients like associated primary disease and alter physiological, anatomical, and physiological changes during pregnancy. We may face the difficult intubation in these patients, risk of aspiration. These patients are usually volume depleted.
Okay.
And the patient may have altered coagulation profile.
Okay.
And if patient present with seizures, we also have to look after for anticonvulsant therapy.
Okay. Okay. So if you can improve the answer, Sumera, because your answer is not wrong, but it is not correct. Because in this case, they are asking you about preeclampsia. Okay. So you can say that in addition to all the challenges which we have in any pregnant patient, like difficult airway and physiologic, like this one, risk of aspiration and altered physiological, pharmacological, and anatomical changes. In addition to that, in this patient, because this patient will have volume depletion, but the main thing is hypertension and risk of fits. Okay, even if this patient did not fit or patient already have fits, this is your main concern. Okay, because you have a patient in which blood pressure may be very high, and in if there is acute hypertensive crisis, patient can have CVA, patient can have MI, patient can have pulmonary edema. Okay, because of the, and in addition to that, this is fits. Okay, so these are your main challenges that you have to tackle the hypertensive response. Okay, so this is one thing. And as you told, volume depletion, so because they are intravascular, this vasoconstriction, so their effective circulatory volume is decreased. So this is another thing, as I told you, as you told. And because there are coagulopathies, Okay. So what is the challenge for you? That if you are planning for central neuraxial block, which is the usual common thing in otherwise pregnant patient for cesarean section, this will be challenging. Okay. So you will just tell that coagulation because of coagulopathies. What is the result? The result, the challenging is central neuraxial block. Okay. And this patient, as we discussed before, that this patient is at risk of acute kidney injury. So you have to maintain and think about it, because there may be baseline renal impairment, okay, which may lead to acute kidney injury and failure. Okay. So these are the main specific challenge which you will have. So now you can go to the individual, that how will you control the blood pressure? Because one management will be outpatient management, which may be usually by methyl dopa, okay, or labetalol. So now, as an emergency or in OR, how will you control the blood pressure? Yes, please. Yes, Sumera, or anyone wants to speak out?
We can use labetalol,
Okay. What else?
and and even we can use so that is sodium nitroprusside.
Sodium nitroprusside is third.
Nitroglycerin.
Hydralazine.
Okay.
Okay. Hydralazine and labetalol, they are most commonly used. Clinically, what will be the difference if you have a patient with labetalol and if you have a patient with the hydralazine? What will be the main difference which you can have?
Heart rate.
Yes, this
Heart
patient
rate.
heart rate will be more stable, and this patient will have increased heart rate. Okay, because this is pure vasodilator and it is alpha beta blocker, labetalol. Okay. For nitroprusside, you definitely need intraarterial blood pressure monitoring and in infusion. Okay. So in addition to that, which medication you can use which will control the blood pressure?
GTN.
Who's telling GTN? Yasin?
Yes, sir.
Yeah, remember one thing. Yes, it is GTN is the most favorite in our OR. But remember one thing, this is primarily not antihypertensive. Okay. This is not primarily antihypertensive. So you can tell about it, but it is not the prime antihypertensive medication. It is anti-anginal. Okay. But unfortunately, we are using it as antihypertensive. It is not pure antihypertensive because it is coronary vasodilator. Okay. It has
Okay, sir.
less it is venodilator. It has generalized venodilating effect as well, but it is mainly, it should be mainly used as a coronary vasodilator. Even if you are using it, you can give small boluses as well, which is actually uh, not the first line. Okay. You labetalol, even in practically, if you have labetalol, that is almost good in every patient except if you are thinking about asthmatic patient. Otherwise, labetalol is a medication which may be used in almost all patients. So this is you are missing one very important medication. Yes, Sumera, are you telling?
Calcium channel blockers.
Calcium channel blocker. Okay. Before that, it's also being used. You are right. Blodipine or nifedipine. You people are missing very important medication. It is not only for fits, my dear. It is for blood pressure control as well.
Magnesium sulfate.
Magnesium.
Thank you very much.
Magnesium sulfate.
So why you are mixing it? Magnesium sulfate is, what is the role of magnesium sulfate? Why you are using it here?
Neuroprotective.
I'm sorry.
Neuroprotective as well.
It is membrane stabilizer. Okay. This is one thing. It is vasodilator. So it actually neuroprotective, yes, neuroprotective by membrane stabilization and vasodilative effect. It will also control the blood pressure. Okay. So just have a look in the text what extra thing they have written. Control of hypertension, drugs. You see, the role of diuretics will be for the like if the patient is overload, a patient is having edema. But remember one thing, diuretic is not the not a very good choice. You see there what they have written. Only use in pulmonary edema. Don't use it primarily to control the blood pressure. So they have written it here, but remember one thing, diuretic use is very, like, it is one of the medication which is terribly misused medication. Okay, so this is one thing. Alpha blocker they have written here also, but alpha beta blocker is the labetalol is the one of the best. That's why they have written here for oral patient when they are using it, methyl dopa and labetalol. Okay, not only oral and but also in the emergency. So nifedipine, as I missed alpha blocker actually, calcium channel blocker actually. So this one is here. So this is the most important thing, magnesium. So uh, remember one thing, when they are asking you about magnesium, they will ask you how to load it. Uh, I think there is another folder. There is a whole protocol how to give magnesium. Okay. In some books or some texts, you will find intramuscular as well. But practically speaking, when you want to start magnesium, what you should see, what should be make sure, what should be the prerequisite before starting magnesium?
RFTs,
Uh,
normal RFTs, renal
Not
function.
RFTs, not
Normal renal
reflexes,
function.
deep tendon reflexes,
I'm sorry.
deep tendon reflexes,
Yasin, your voice is not audible.
deep tendon reflexes.
Again, come out of the books, my dear
Sir,
friend.
we will see the urine output.
Urine.
Urine output. This is the most important thing. If patient does not have urine output, don't start magnesium, because it can cause severe toxicity. Because there is, other uh, because magnesium is excreted or maintained through kidneys, magnesium levels. So if you give magnesium in a patient without urine output, it can cause serious problem. So it is better that you may start the perfusion. You can, because anti-epileptics, there are a number of medications. Okay, so you can go for some other anti-epileptic medication. Don't give magnesium if you don't have urine output. Deep tendon reflex is fine. It's not a wrong answer. But if you answer this question in exam, the exam, you are just like itching the examiner. He will be angry that you are not telling the first thing. Then you can have the baseline magnesium levels. Okay, before starting. Then, of course, deep tendon reflex, respiratory sufficiency, okay, and cardiac, like in the form of ECG, this in the form of spirometry, okay, of course, or SpO2 or anti, like, but this is for monitoring. Before you start, always remember, there are some people think that magnesium cause renal failure. No, okay, magnesium does not cause renal failure. It is only that you cannot give magnesium if there is no urine output. Okay, because if there is no urine output, a patient will have toxicity. So this is the first thing you don't forget. And then gradually, as the levels are increased, first peripheral effects come, then respiratory effects come, and then cardiac effects. Okay. So this is what they have written here. And don't be confused by the levels. In the exam, if they are asking you the levels, and even in MCQ, remember one thing. Please, I'm just trying to tell, because some people will go out that, sir, we have not passed the written, so this discussion you are doing for only for Viva. So that's why I'm trying to be. And in even an MCQ, they have maybe written millimole and you are picking it milligram, or they have written milligram and you are thinking about millimole. So always look at the unit. Usually the level which is in millimole, double that is milliequivalent, and double that is milligram. So for example, if it is 2 to 4, I think if I'm not wrong, it is around 6 to 8 in milligram, and 4 to 6 in milliequivalent. But this is millimole is more significant because it is the SI unit. Okay, it is the SI unit.
Sir, if you have to convert millimole into milligram, you have to multiply by 18.
No, my dear, this is a different for different ions. This what you have told is for only for which one?
Glucose,
Yes, thank you very much.
RBS.
Yes, it
Okay,
is
sir.
only for blood glucose.
Okay.
Okay, so correct yourself. If you are converting milligram per dl into micromole, what is the conversion? Do you remember this thing? It is
No,
88.
sir.
88. Okay. 88. 1 milligram is 88 micromole for creatinine. So that's why, again, come out of your holy manhus book of Morgan. If you want to destroy your concepts, please continue reading. If you want to have the correct concept and come out of the exams, come out of the books. If you want to be a good anesthetist who has grip on the subject and dealing with someone, mother, father, brother, sister, so please try to come out of the books. I again have the same request to you. Yes, Mozama? Unfortunately, Mozama, you write the message. We cannot hear you.
Millimole per liter is equal to
I'm sorry, Mozama, your sound was distracted. Try again.
Sir, 1 millimole is equal to 1 milliequivalent.
No.
Sir, can
No.
you hear me?
Your sound is distracted. You just write the message. Okay. There is some
Okay,
problem.
sir.
Okay. So if you have any toxicity, will stop the infusion, and even maybe patient may have need to be CPR. A patient might need dialysis. Okay. Or you can give calcium gluconate to counteract the effects of magnesium. Okay. And if you are patient having magnesium, because maybe we will not be able to finish the management. I think I will take one more session for the management. Okay. So tomorrow, inshallah, we will continue from where we stopped. We will be discussing the anesthesia management, GA, spinal. But I think uh, the preliminary we have discussed. Okay. So tomorrow we will continue from here. Any questions before we finish? So tomorrow, inshallah, we will discuss about the management, GA, spinal, epidural, what are the challenges, what are the problems. Okay. So I will upload this discussion on YouTube. If you have any question, just feel free to ask. Remember one thing, some people become annoyed that I am telling, I'm very against this so-called Manhus Morgan. The problem is that it never gives you a vision. Remember one thing. It will just tell you facts. You are not in class 5. That you are like a good boy. You are the teacher is asking you a question and you are telling 1, 2, 3, 4. You are managing the patient. You are having like you have so much responsibility. If you only have a tunnel vision, which is created by this bloody book, Believe me, you will suffer whole your career. I have suffered so many years because now I realize that if someone I never had a chance to have a discussion like this, believe me. Okay, because if I give you the vision that how you have to study or what are the important things which you should know, you will be struggling in the lines of the books, and that will not give you any benefit. You should have a concept which you can reproduce even after years. This is the only thing, because after even 1 week you have read a chapter from Morgan, after 1 week you don't remember anything, and people are still asking you to worship it. So please, this come out of it. Okay, so I'm doing jihad against this book. I don't know how many people will be convinced in my before I die, but I will try to do it till my last breath, because the one book reading is a crap, outdated, obsolete concept in 2022. And whosoever is asking you to read only books and paper will come from Morgan and paper will come from problem oriented and examiner read this book, please just say sorry to them. Okay, because they are absolutely wrong. I totally disagree, because the any book reading is one book reading is always giving you a tunnel vision. If you want to know the subject, you will have to peep into different books and you will have to know what you want to know. Till the time you don't know your enemy, how will you kill your enemy? Okay, so thanks a lot everybody for joining. Inshallah, we will continue tomorrow. Yes, Munazza?
So you was telling about double of millimole is milliequivalent and double of milliequivalent is milligram.
If I'm not wrong, I'm not 100% sure, but I
Uh,
think it is like this.
so you was telling about micromole. What's the formula to
Micromole is
convert for
for
conversion of milligram to
micromole
micromole?
is for this conversion I told you 88 is for creatinine. Okay, so creatinine, if you want to convert 1 milligram per DL into micromole, because in like in Saudi Arabia or in a British system, they are having micromole. So in some laboratories finding, you will find micromole. So 88 is 1 milligram. So and then you can double it like that. Okay.
Okay, right.
Okay. So thank you very much. Are you clear, Manazza?
Yes, sir, clear. Thank you so
Oh,
much.
okay. Bye bye. Assalamu alaikum.